everyone. We will see Kateri Raymond. She's a PhD student. She's occupational therapist. She works in Sherbrooke International Research Group on neuromuscular diseases. She was part of many research projects on myotonic type 1 myotonic dystrophy. She worked on the feasibility of a self-management program for affected people and their families, on changes in the capacity of upper limbs, social participation throughout the year, and improvement of the practice of occupational therapists working with people with a type 1 myotonic dystrophy. Do I need to do this introduction in English too? She asks. Okay. That's my pleasure to introduce Mrs. Raymond. Hello, everyone. Thank you for being here. I'm here to present the obstacles and leverage of participation over time among adults with type 1 DM. That's my plenary research for my PhD essay. I hope that there will be a discussion period because I passed documents to be able to discuss easily on the results. I will talk about 4 aspects. I will just give you a brief overview of type 1 MD. We'll talk about social participation according to the human development and disability creation process. I'll tell you the method I used for my results, and we will look at the leverage and barriers to participation and clinical impact of all the results. Now, for type 1 MD, in fact, of course, we have the highest prevalence among adults and over-prevalence in the Saguenay area, as you saw this morning. It is a multi-systemic disease with it impacts many systems, a great variability of systems with a few clinical phenotypes. Today, I will mainly be interested in the adult and late forms. Adult includes the early form of the disease when symptoms happen around 10 years old or in the 20s and then during the 40s. For adult and late phenotypes, we are more and more describing the disease as an early aging phenomenon. We know that there are many different disease, which is weakness, muscular weakness, cognitive specific troubles, fatigue, and also something in the environment, like it's a family hereditary disease. We notice that those who are have a low income and a low social support from their environment, in the different studies, this is what we saw. And we find people who have a lot of challenges in their social participation in the former presentation. This is really at the heart of the issue. When we talk about social participation, it's a topic we've been looking into for more than 30 years. The World Health Organization says we have to optimize social participation. It is an important target for intervention in the health, and not surprisingly, because social participation is related to death, morbidity, cognitive health, and quality of life, namely for those with type 1 MD. When we talk about participation, we talk about doing daily and social activities that ensure survival and development of a person in society. We are really in fundamental values we have here about autonomy and participation. in this conceptual framework developed in Quebec, when we talk about social participation, we'll say that it is influenced by personal factors and also environmental factors. They will interact, and this type of model allows us to assess the causes and consequences of diseases in social participation over time, since we can see that personal and environmental factors will change. It will have an influence on social participation. When we talk about participation, we talk about 12 different activities divided in usual activities and social. We talk about social roles. I don't talk about a role as a mother or a brother, but activities. Truly, it's about activities where people will be involved to meet their families and have relationships in society. When we talk about social participation with people with a type 1 MD, it is a paradigm. Well, people will have difficulty doing their activities. The studies show that 21 to 64% of people have limitations in all types of participations. They will need to have the support of a human being. The most impacted activities, it's housing, traveling around, moving around, work, and leisure. But there are changes over time. It's not the same activities that are impacted at the same time during the disease. This brings us to understand better the change with studies, longitudinal studies, though studies done over a 5 or 10 year period. We see that nutrition, preparing meals, going to restaurants and grocery store and then eat, personal care, washing, going in and out of the bathtub, taking care of the house or walking inside the house, using the different furnitures like a sofa, turning on the AC, recreational activities. They will have more and more limitations with these activities over time. And what we notice is that people will need to adapt and change their routine. They will let aside activities they love or partially participate in other activities. This is what comes out of the current studies. In 2015, during my master's degrees, I looked specifically in the changes in social participation in Quebec. That's a 9-year study. The findings are similar to what was seen in scientific studies. People would have more difficulty doing activities over time, but there were people who had less difficulties also, more or less. It depends. Like for nutrition, 33% of people had a reduction, but close to 5% who improved in preparing their meals. Body condition like washing, training, relaxing. Close to 55% had limitations, but 12% improved. And so on, personal care, housing, moving around, community life. The same pattern was there. Some people had losses and others improved. This raises a lot of questions. How come some people will have more loss than others, and what makes some people improving over time despite they are living with a disease that will evolve and there will be more losses? Oh, I forgot to talk about recreational activities. This presents challenges for healthcare professionals. There's no cure. They have to live with the symptoms over time. And this brings a lot of challenges in the field of social participation. It is a very complex disease. It evolves. All this together will bring difficulties to offer the right services at the right time to the right person to prevent any limitations in their participation over time. It is necessary to understand better the leverage and barriers to participation with adults with type 1 muscular dystrophy, because it is we will be able to give the proper tools to the healthcare people. They are doing a great job currently, and they are using their clinical experience, communities of practice. They ask questions. They have partnerships. Unfortunately, sometimes it is difficult to know on the long term how it will evolve their participation. Very few studies looked into that. We have to use factual data according to the experience of these people, and sometimes it's difficult to take proper decisions concerning interventions and when to have these interventions. So, and it is not everybody who has experience with myotonic dystrophy. They will meet maybe once a person with that disease in their practice. Understand better leverages and obstacles. It is very important. My PhD project was to understand better the changes on the long term and the factors that influence them. To meet that objective, we used a mixed sequential explanatory plan. We had, in fact, we did two studies on one. We used a quantitative study where we would collect data with questionnaires, and we had a qualitative study then when we would interview people, talk with them, see the key people who would better understand the barriers and also the leverages to participation. For quantitative study, it is a secondary study to a cohort study that were measures in two different times, in 2002-2004, and met 9 years later between 2011 and 2013, 114 adults with DM1 of 18 years old and more. So that's a lot of people. And we collected many interdisciplinary data, for example, their physical capacities, cognitive capacity, their environment, and we assessed their participation with the lifestyle measurement. It's MAVI, maybe you know it, 77 questions in that questionnaire asking, this person has difficulty, does the person need help, only specific help, what kind of help, and the level of satisfaction in doing different activities. So the score on 9 helped us to see a 9 with an optimal participation and 0, which was no participation. For the qualitative study here, we studied many cases. We met people, triads of people with DM1 recruited among the 114 adults in the main study. We met one member of the families and one health professional doing the follow-up for many years. The 6 triads I made between November 2017 and March 2018 with semi-directed interviews. So what they saw over time, what were the changes in their participation, and what were their biggest challenges and the facilitator for their participation. I will try to show you today the results and what was said by these people. For each person recruited, people with a disease, I reviewed their medical files from diagnosis until now to be able to have factual data on the crossroads, how things changes, how participation had to change over time. Without further delay, let's go into the leverages and obstacles. A quantitative study, where we have the 114 participants. Most of them were women, 72 women, 42 men. People with the adult phenotype, including the early form, and 24 with the late form. People were between 20 and 77 years old. The average age is 43. It has an impact on participation. People don't have the same activities depending on their age. So duration of disease, people had an average of 20 years with symptoms. Some just had symptoms for 3 years, and others had the first symptoms 40 years ago. The age of the first symptoms between 10 and 43 years old. So it was mainly the adult form. Concerning their environment, people were mostly living with at least one person. Very few people were alone in their home. People would receive home maintenance services, more than 40%, showing that they already had a difficulty in that kind of participation, or they chose to have help and put their energy somewhere else. Half of them moved during the study. This means that probably the features in their environment changed. Maybe this can influence the data in participation over time. It is more difficult to identify over time how come the environment is helpful or not. With the 114 participants, what we did, we looked at what changed in my master's degree, as I said earlier on, and we wanted to know what are the predictor of changes, why one person will have more limitations or less limitations over time. This is what I will present for each activity. Well, first activity will be nutrition, or feeding oneself, preparing a meal, going to the restaurant. I identify different predictors. When we talk about predictors, it's about elements that will allow us to detect people who would be at risk to have difficulties over time. We cannot have a causal relationship. It's not because we identify a factor now and it will have a positive impact in 10 years. Hopefully, we could. My study is not strong enough to show that, but we cannot make that association. However, we can say that factors I'm showing today, the predictors of participation, this is what is associated to long-term limitations, and maybe we can raise yellow flags in clinic. It's interesting because we can detect early people that might be at risk and intervene early to prevent limitations, and also maybe she would be waiting for a few years to have her home changed. The waiting lists are very long. For nutrition, we have many predictors. First, a person will have more limitation if she takes more time to raise and walk, time up and go, as we say. And so if it takes a long time to stand up and walk, it will take more time to prepare meals. And fatigue, someone who has more fatigue, the cramp fatigue, someone who has wears intelligence score lower will have more difficulty. Here, this intelligence score, I used it as a proxy, something that is associated to cognitive functions, capacity to read a recipe, to use the ingredients safely in the proper order. And just want to, a little caveat, don't misinterpret. It is really associated as a proxy for the cognitive and not intelligence of the person. We had the lesser, the person doesn't feel supported by the family. She might have help. difficulty. Now, the fitness. It's about sleep, but training and physical and mental training. More daytime sleepiness scale, more fatigue, lower vital capacity. Someone who has less short breath has more difficulty here. It makes sense. And a reduction in stress in the dominant hand. Personal care. Also, there's this factor of time up and go. If it takes more time to stand up and walk, would have more difficulty taking care of herself. And it's logic, because to wash, to dress up, we need to be able and walk a little bit. There was also a reduction in the use of the hand, personal esteem, or self-esteem. Maybe it's a surprising factor, but someone who has less self-esteem maybe will have difficulty taking care of self, and maybe the person will not take properly care of herself. That's what I can think, but there's nothing scientific. It's just my own reflection. Now, in the home, to take care of the home, cleaning tasks. So one predictor is time up and a longer time up and go. Use of adapted transportation. We ask, do you have a hard time moving around in the home? So maybe using adapted transportation shows that it is more difficult to move around. It can be an indicator that there would be difficulty walking around inside the home. Fewer strength in the hand, and also limitations in the domestic hand. Why having more help in cleaning the home will bring more difficulty? Because if maybe she has a hard time cleaning up around because she has to do it by herself. So having less help there will bring more difficulties. Moving around, driving the car, person with a higher body mass index increasingly use adapted transportation, less strength in the hand, lower perception of impact of myotonia on the daily basis. Why? Feeling that it doesn't have an impact. Why can it is a predictor? It's an excellent question. In fact, what we thought is someone with myotonia and will see impact will have more strength, because the more we have strength, the more myotonia is apparent, and the less you have myotonia, the less you see impact in your daily life. And maybe here strength and myotonia are two predictors that are closely associated. I would use the strength indicator to understand the long-term mobility. Going to community life is going to the grocery store, participating in groups in our community. A person who feels more obstacle in the physical environment, measured with the quality of environment, would have more difficulty. So maybe will not go out. A person sees more obstacles in the physical environment. The impact of myotonia, and also someone who walks slowly will have long-term difficulty. Makes sense, because will be less functional, will less mobile. And reduction, a person who is incontinent will not go out in the community. This result is interesting. we see that people don't go out if they are incontinent. Might be a yellow flag, and I might say that there might be difficulty. Recreational activities. This is very important for everybody. In fact, we can develop, have fun every day. It is one activity that where we would lose more capacities. But for these activities, the most important yellow flag is a perception of obstacles in the physical environment. Have more difficulty standing up and walking, maybe to have less strength, but maybe having poor memory. Were the predictor in various activities, a bit long like this, but I wanted to show you one after the other because they are really yellow flags that could make sense clinically, and we would be able to detect people with the disease. The data were collected. We were looking at the income, sex, and duration of disease, everything put on the same level. The data allow us to control these factors directly.
Now I'm going to talk about the qualitative study. Now that we've had these quantitative studies, well, it's difficult to predict everything. So we predict something that's going to happen 9 years from now. So we have to explain really the whole situation. So we met a few triads. We made interviews, individual interviews. We made a review of the files, and we ended up with 6 persons who participated in the process. So I will give you an idea of their profiles. So first, the first participant, a man of 56 years old, adult phenotype, diagnosed in 1984. Beside him, there was a 60-year-old neighbor for 20 years. Second participant, 40 years of age, adult phenotype, diagnosed in 2002 with her cousin. She had also a myotonic dystrophy, and she was there to talk about her daily life, same age. And the 2 participants were twinned with a nurse of the muscular diseases service. She'd been working with them for more than 10 years, and she was aged 35 to 45 years of age. Third participant, a man of 53 years old, early phenotype, diagnosed in 1980. He was accompanied by his sister that also had DM1. A fourth participant, a man of 50 years old, early phenotype, diagnosed in 94, with his mother, 82 years old, twinned with a nurse who had also a follow-up story for many years. Fifth participant, 45 years old, a man, early phenotype, 94, diagnosed with his mother, 63 years of old. And sixth participant, man, a woman, 52 years of age, early phenotype, 1994, and ex-husband was the respondent. And we had a nurse twinned with a follow-up of more than 10 years, age between 35 and 45. I wanted to highlight the fact that we had 3 men and 3 women, so we wanted to have really something representative. We had different ages, between 40 and 56 years of age, and the persons all had the illness for many years. In the next slide, we see the scale of progression in muscular strength, a MIST, a score from 1 to 5, 1 normal, and 5 is very severe, person in a wheelchair. And the study had shown that about 5 to 6 years after the first symptom, it was usually phase 2, 10 years phase 3, 18 years phase 4, and almost 30 years phase 5. For my 6 participants, the first symptoms all had shown up 21, 14, 16 years. And participants had been diagnosed many years after the first symptoms. So we have a person who received a diagnosis 12 years after phase 2 of the disease. One, it was 6 years after the first symptoms, phase 2, and 12 years in the other case, also phase 2. And 3 persons out of 5 had received a diagnosis when they were already at phase 3 of the disease. A lady for number two here, for 4 years she has had the symptoms. One had had them for 10 years, another one 7 years. So if we compare this, it was 5, 6 years, 10 years, and about 30 years here. No, not really, excuse me, 2, 3, 4, wait a minute. So 5 to 6 years here, 8 years here, and written 8, 9 years, and 18, and about there was one here for 30 years has had the symptoms, but it was only phase 4 out of 5. So it gives you an idea of the progression of the disease with respect to muscular impact for these patients. After that, the first trial, the man of 56 years old. This man had his first symptoms in 82, was diagnosed in 84, and stopped working a few years later. He was living with his parents, was in the army for 2 or 3 years, had worked up to 27 years of age, and he had been, he had to get out of the army because he had problems with alcohol, drugs, and didn't wake up in the morning. In the 20s, he used to see friends, party around, listen to music, bicycling around the city. It was his means of transportation. And he used to go out with friends a lot until very late. He had a girlfriend for a year, but it was always difficult to have girlfriends because it was difficult with respect to sexual relations, and he wouldn't find anyone understanding enough to share his life. He lived with a cook. That person helped him cooking. After when he was 30, he went to live alone, where he still is. That person is, for some about 20 years, has started to build a social network where he lives. A man who's had difficulties in daily activities in 2003 and domestic life in 2007. The first episode of dysphagia a bit later, and difficulty to walk outside. So only for some years did he start using a cane to walk. So for about 30 years, the symptoms had been present. Before, he actually had problem going out of his house, and he started to fall repeatedly starting in 2012, and he has had a quadriporter, and his social life then started all over again. He could go out more easily, especially in the summer, go and see his friends that he had lost contact with time. With respect to the second case, the second triad, a woman of 40 years old, received the diagnosis at 25 years old. Only for 4 years she had had the first symptoms. Soon after that, she started having difficulties with her domestic life, carrying weight. That was what bothered her most at the beginning. She had fibromyalgia in her life story. It could be a factor that would have influenced her participation, because if you live with pains coming occasionally, it stops you from participating in activities. We have seen that this person with time had to move often. We could never adapt her environment to really be more functional. And this lady had problems with cannabis consumption as well. It was difficult for her to have any stability in her life. That person had a good libido, so she had many partners, one after the other, and they could help her with her domestic activities. But at some point in her disease, she really started to have more difficulties to move around. She fell often. She couldn't go out so well outside of the house. She's more in the suburbs, so it was more difficult for her to have access to services. She was more isolated. She would stay home a lot. She's satisfied to stay in her home because she has a lot of activities in the house, but she must receive a lot of help from her cousin, her partner of the time, to go and buy food and buy clothing. She's always tired, and she's into dysphagia now. A lot of events happened in her life, and which makes life more difficult for her. Third triad. A man of 53 years old received a diagnosis in 80, a year after seeing the first symptoms. 10 years later, he stopped working as a mechanic. It was difficult to work in the engines, and so he had to stop working. He started to fall. About 12 years later, he was very worried. He was afraid of going out of his house. He started she started having difficulties domestically. She had help to help him. That person had to find ways to better deal with his falls because he was paralyzed by that. In 2012, he started making dysphagia more and more. And 2015, he started to have aspiration pneumonia, and eventually, last year actually, he had 3 pneumonia in 1 year, and that has really led him to use a wheelchair because he didn't have the energy, the strength. He was tired of falling and not having air. So he decided to use the wheelchair to facilitate his moving about. It was a difficult choice for him, but he's more functional like that now, and it's safer for him in his daily life. The fourth person I wanted to talk about, and 2 more after that. A man of 50 years old received a diagnosis at 26 years old, always lived with his mother. He tried. He left the Chibougamau to move to the Saguenay area, and he got there, and he had no social network. He was very active. He played hockey. He was a goaler. And when he ended up in this new environment, it was difficult for him to meet new persons. He was never able to integrate in sports groups, so he stopped practicing sports, and that's when he started losing more and more capacities in terms of strength, because what could maintain him a bit more active disappeared from his life. And a few years later, he started to fall from time to time, had more difficulties with daily activities, and for the past years now, he's been falling a lot, and he has to wear prosthesis and orthesis because even though he doesn't like that. Fifth person, 55 years old, received the diagnosis at 25 after many complications after giving birth to her second daughter. She had a husband, 2 children for most of her life, so it helped her dealing with her life at home because she received help in her domestic activities, and the more the disease advanced, it was difficult for her to handle objects. She started to fall, and after that she started to have more difficulties going up the steps, and she started falling more and more. This lady was when her husband left her, she went to different places where until she finally found the right place. She had a wheelchair. She was in a healthier environment with persons around her supporting her. Now she's participating in many activities. She has fun. Despite all the activities she's gone through, she really ended up in an environment that was good and positive for her and for her participation. Last person, a woman of 52 years old, similar profile, a husband for many years. And what she saw most is difficulty to prepare the meals. That was very important for her because she really likes cooking. It's a lady who lived with her husband most of her life. Finally, her husband left her because she was asking too much from him. So he left her. He knew she could do more than what she claimed she could do. And finally, when she ended up alone, indeed, she realized she could do more things. But her husband still goes, her former husband still goes to help her every day for more difficult tasks that he knows that she cannot do. So these 6 persons, if I look at all that, if we look at all the elements that I have drawn from the interviews, well, people don't accept, but people do learn to live with the disease. I live with it, they say, but I'll never accept it. We continue to be positive, to have a social life. It's good for one's mind. A nurse would say, you can't really accept that. You cope with it day after day, but you live with it. That's the best way to be happier and to participate more. People had to adopt strategies to solve problems. You have to find new means to solve the problems. Interest people had would lead her to be more active in their daily life and to do the same activities as in the past. It was important when you like to do something to go and do it. A person said to me, you know, I have to push my head. People don't want to go out. They're afraid. You don't have to go to do that. You're going to die in your home if you do that. Even if you have diminished capacities, do it. Because I like it, she would add. The person who can more reflect and plan, that was helpful. Self-criticism also. There was a nurse who said self-criticism is always good. That's why some nurses would say the person would deal better. In terms of environmental factors, well, physical support. Someone would say, I know she's not strong enough in her hands, so I bought her better knives so she can prepare her potatoes, but I will do it for her. When I know she really can do it, like with steak, I'll do it for her. I know some people would say we have to motivate them, give them psychological support. A lady said if she can do something now and it's more difficult, you have to push her. Come on, go, go, go. That's how the person can continue participating. Different tools, devices that could help people. That's for the dryer, easier to open the door of the dryer. A little tool to open the pots, a lamp that can be lit just touching it, support for the bath. All these things that help you throughout your daily life. Quadriporter, some really enjoy that. It's a sunny day, they go outside. And some barriers, also personal barriers, environmental barriers for the symptoms. Regarding personal barriers, well, the symptoms of the disease, muscular weakness, fatigue, diarrhea, they go out less, problem with their balance, they're afraid of falling, it will prevent them from going out. But also they are afraid of being stigmatized, not because they have a disease, but because they have to walk about with a technical aid, even if it's only a cane, a wheelchair. People will look at me. I'm afraid of that. I don't want to go out. No driving license. a lot of hospitalization, like this man who had 3 pneumonia in 1 year. He was deconditioned. He lost a lot of autonomy. So it's very important to see what could prevent that from happening, especially with respect to pneumonia, especially how to avoid dysphagia, brush your teeth to avoid infection, apathy, environmental factors, to have a good, it's important to have a good organization in your home. Here's a bath, and that's a post that was there just beside the bath, but he can't go there with his wheelchair. He must take a bath sitting at the table. We have to think about these things before putting some tools around. It's okay if you can walk, but the person cannot walk, so it has to be moved out of there. When there's snow, you can't go out. Stigmatization. Some persons have said that they would receive comments. It was difficult when they go out. They were afraid to be judged on their quadriporter. But that was a long time ago. Stigma are disappearing in the environments where they were. It's an environment where there are more prevention and promotion and of health, and people are more sensitized. So these stigma are disappearing. Losing friendships. A lady said, I used to love going, having a coffee with my friends, but I have no more friends. They're all left, more or less. So the person had no one to go out to have a coffee with. So she found no interest in going out. Certainly a barrier for participation. So I have 5 more minutes if we want to have a few questions. So we can use these 5 minutes for some activities and the questions. Maybe I would ask you to put on the white sheet of paper that I have given you, according to your experience, how these results that I just presented could be useful to improve your practice. Are there things that you were surprised about, things you do already? And on the yellow sheet, are there elements that that lacks here that you know could help, that I haven't mentioned, things that could make a difference in people's life? So please take a few minutes, 30 seconds, 1 minute, to write in the white sheet how to improve your practice, what you were surprised by. On the yellow sheet, what you deem missing in what was presented. And when this will be done, I would ask you please to use the mics to share some reflections with me or ask a question. Would anyone have any reflection to share? Gilbert Lefondren, Centre Bruno. I think you have identified the 4 daily habits more affected by the disease. I was wondering if there were a 5th or 6th daily habit that would be most affected. Would that perhaps be responsibility? Because what we see a lot at our center is a lot of problems linked with cognitive disorders, apathy, the capacity of the people to organize themselves, to make sure that their responsibilities be taken into consideration regarding personal organization, finances, administrative problems. We have a specialized staff helping these people to organize themselves. Did you see that in your study? It's a very good question. In fact, regarding it's a self-report where people must make a judgment on their capacity to solve their daily problems, and responsibility as such didn't come out. People 8 or 9, people would say we don't have any difficulties. Sometimes maybe they would need a little technical support, memos or alarms, but no more than that. And it didn't change with time either. So even after 9 years, there was no significant difference or clinical differences on responsibility. Same thing with respect to communication. We had no difficulty. People deemed they were easily understood. It was difficult. It was not difficult to speak before a group, reading, etc. It's quite clear because, in fact, the persons around them would indicate that they indeed had problems in terms of responsibilities, and they were one of the first persons I interviewed, the man of 56 years old. He must take care of her mother, of his mother. She has Alzheimer. He's ill, and he's been designed by his family to take care of his mother, and he can do it because his head is fine, but it's not the case of everyone. Regarding the parental role, it's a big issue, and sometimes the person does not see the difficulties, and it can create problems with their environment, with their network. Yes, indeed. In my sample of 6 persons, not very much, I had only 2 women with children. One of these women had 2 healthy children. She had the other one had a congenital disease within her child, and she saw no problem taking care of her child. And her parental role was well supported because she had a husband most of her life, and he didn't have the disease. Now the husband is gone, she's alone. She continued to help this child as much as she can. But yes, it's important. It's a person with more cognitive problems, it can become really problematic, and it comes out in the practice guides that I'll present tomorrow, and you participated in it. The parental role that must be assessed, especially with young children with specific needs, no communication. The person must have support from the environment and the community, the health system as a whole. Thank you. I would like to ask you to keep the sheets of paper. I'll take them back. Even if we didn't really have time to share all that together, I think it will help me to have your reflection because you have a very important experience for me. I will use what you have indicated to go more into details in my reflection, to pursue my researches, because this is only preliminary and it must be explored further. And thank you to you all, and thank you to all the persons who participated in the project, the sponsors, the time of the nurses, everybody who supported me throughout the project. Thank you very much. I would like to thank Madame Raymond for her presentation.